Thank you everybody for joining us. It's Friday afternoon here on the eastern side of the US. Today we have a very exciting webinar with my co-chair, Jose Gomez Arroyo from UO Cincinnati. This will be the first webinar of the Diversity, Equity, and Inclusion working group of the Pulmonary Circulation Assembly. As the DEI working group, we want to provide a platform to discuss areas of interest for everybody with an interest in pulmonary vascular disease. And today's webinar is going to be quite interesting because any of us who wanted to pursue a career in pulmonary vascular disease knows how challenging that can be. And that can be more challenging for some more than others. We're going to hear the trajectories of very successful physician scientists here in our panelist group, and a few housekeeping items. So it will be a very informal conversation, but if you have any questions at any point, please write down your question on the chat box, and Pepe and I will do our best to go through them. With that in mind, allow me to introduce to our panelist group that we have today. We have Gustavo Jerezi from the Cleveland Clinic. We have Belinda Rivera-Lebron from the University of Pittsburgh. Pepe, I don't know if you want to introduce the other two panelists.
Sure, we have Eda, hopefully I'm doing justice to your last name, but this Eda Spicker from the Stanford University, and Gustavo Jerezi from the Cleveland Clinic.
And
Great.
Roberto Machado, who you got.
Roberto, sorry.
And Roberto Machado from Indiana University, my good friend.
That is correct.
All right, so we're going to go with a round of questions for all of you. Eda, we're going to start with you, but we would like to hear about your background. If you could tell us about your background and your area of expertise in PH, and how did you get started into pulmonary vascular disease?
Yeah, so I'm originally from Germany, and I trained there I did my residency there and my fellowship in pulmonary critical care. And I saw, like, during the fellowship, I had to take care of many patients with pulmonary hypertension. And it was frustrating at that time. This was before 2000. We didn't have many medications, and I followed the same patients also into lung transplant. And it was then also frustrating to see that then patients often had rejections, and they were often young women. And so I wanted to learn more about the disease and to ideally find ways how to better treat it. And this is kind of funny. I mean, I looked up on PubMed who does basic science research in pulmonary hypertension, and who had an active research lab. And I came across Marlene Rabinovich. And at that time, she was still in Toronto. And then I asked her whether I could join her lab as a research fellow. And she then said she would move to Stanford, whether I would also join her lab there. And so then I joined her lab in 2002 and worked as a postdoc for 4.5 years in her lab. And then really, this was kind of my first real exposure to bench research. And I did like a lot of cell culture experiment, animal modeling. I wanted to also see patients again in the US. And so then during the last years of my postdoc, I did these USMLEs. And then I had already made contact to the clinical pulmonary hypertension group at Stanford. And it was essentially some people who really helped me get my foot in the door. And one is Ramona Doyle, who used to run the pulmonary hypertension clinic there. And the second person is Vinicio de Jesus Perez, because they both advocated for me and said, like, because I wanted to do like a fellowship so that I work for 2 years in an ACGME accredited program so that I would get my California license. I didn't want to repeat my whole residency because I had done, the residency and fellowship in Germany. And so both of them kind of introduced me to the leadership there. And then I applied and I was able to then work these 2 years in pulmonary critical care. And during this time, we were also getting a green card, so that I would be able to stay longer and also apply for federal grants. And then I went back a little bit to the lab to work on a project where I could apply for a career development award, a KO8. And when I had enough data and I had some publications for my postdoc, then I applied for a KO8 and I got the KO8, and then I could apply for a faculty position. So I applied at different institutions, and also Stanford had an opening. And so that's kind of in 2011, I ended up then joining the faculty there. And then with a lot of help from the division and a lot of support really from Mark Nichols, the division chief, who really said, we want you to succeed. And even if you don't get a grant immediately, you will get it and we will support you. So this kind of how I was able to lead my career. But I think what I really want to give credit to people that support you, and get you into something, especially when you are from a foreign country. You need mentors, or you need sponsors to help that help you. Okay.
Thank you, Eda. That was very interesting, very fascinating. Pepe, you want to go next?
Yep. So I guess the next speaker is Gustavo Jerezi from the Cleveland Clinic. Gustavo has a very interesting background. I think he is coming from Peru. So I think he graduated from the sorry, can you guys hear me well? Yep. Sorry, from the Universidad Católica de Santa Maria in Arequipa, from El Peru. With his residency at Jackson Memorial in Miami, and then his fellowship at the Cleveland Clinic, where he actually has done an incredible tenure and career. Now currently the director and the section head of the Pulmonary Vascular Disease division, I guess, department. And he is a director of the CTEC program at Cleveland Clinic. So, Gustavo, why don't you tell us a little bit more? How is it that you've managed to accomplish this incredible career so far?
Yeah, thank you. I don't know about incredible, but happy to share my story. Yes, as Pepe said, I'm from Peru, originally from a city called Arequipa in southern Peru. That's where I did my medical school, indeed, a year in some university called Santa Maria, but then the rest was in the public university called San Augustine's University. So I graduated there, and as in many other Latin American countries, I had to work for 1 year in sort of a publicly underserved area in Peru. That will allow me to work in the public sector if I wanted to do that. But back then, I already was interested in coming to the US for subspecialty training, not necessarily to stay here forever, but definitely to get subspecialty training. In fact, the plan originally was for me to go back after training, but of course things change, and we can talk a bit more about that. So during that year where I was working, I took the time to apply for the steps and all the necessary tests that we need to take. And I did my residency at Jackson Memorial at the University of Miami. This institution has an interesting program where they devote a number of positions in the residency program for internal medicine to Latin American applicants. So this is a good resource, at least for folks coming from Latin America. And from there, and this is actually where my interest in pulmonary vascular disease started, this training program for Latin America also allows you to come as a student. So years prior to my residency, I did a couple of observerships and that was actually my first exposure to pulmonary hypertension. I was a fourth to fifth year medical student in Peru, and I was doing a cardiology rotation at Jackson. And there I met for the first time a young woman with what I understand now to be idiopathic pulmonary arterial hypertension. That was something I had never heard in my life, never even read about it. And this particular woman was pretty much dying in heart failure and was started on intravenous ibuprostenol. This is, again, late 90s. And her life changed around. So that was fascinating to me, even though I didn't really quite understand what was going on. And so fast forward to residency in Miami, I remember distinctly, and Roberto may remember Dr. Mark Gelbart. He was an amazing internal medicine clinician. And I would go back to him with questions all the time, because I remember in internal medicine, everybody was getting an echo, and everybody would have some sort of description about the right ventricle and a right ventricular systolic pressure. And again, this is early 2000, this is 2001, 2002. And I didn't really know what to do with that as an internal medicine resident. And I would ask around, and very few people around me knew about that. And this is around the time where the New England Journal Review articles had come out and Bosentan was approved. So it was really the beginning of sort of a widespread understanding of pulmonary hypertension. And Dr. Gerber was the one that, for the first time, started to tell me about the importance of the right ventricle, particularly in the context of left heart failure. But it was really motivation for me, because I realized that very few people around me understood the right ventricle and pulmonary hypertension, and that piqued my curiosity. So when my time came for fellowship, I looked for fellowship programs. They had a strong pulmonary vascular disease programs, and luckily I was accepted at the Cleveland Clinic. Then credit there to my who became my mentor until now, Dr. Ryan Dweck. I think and for some reason, he took a liking to me, and very early on, I had expressed a desire to work on pulmonary vascular disease. And so I think that with that, I was taken in the Cleveland Clinic fellowship program, and I ended up staying. But I can tell you the rest later if it's of interest to people.
Thank you. You may say that it's not incredible, but I truly believe that this is a remarkable career. So thank you. Now it's the time for Dr. Roberto Machado, coming from Indiana University as well. So Dr. Machado, would you like to give us a little bit of background and what brought you here, and then what made you stay?
Yep. Right. Yeah. So I'm a little older, so it may take a little longer. So so I'm from Brazil, the southernmost state of Brazil. That's where I grew up. That's where I went to medical school. And if you ever been to Fogo de Chão and some of those Brazilian intoxication places, meat intoxication places, that's where they start. So anyway, I came to the US in '96 after graduating, a few years after graduating from medical school in Brazil, where I worked for a couple of years. And my motivation to come to the US were basically related to, seeing attendings that I had during my growing up in Brazil in medical school and training in the US. And I was very impressed about how they took care of patients, how they thought, how they handle complicated cases. So did my steps, came to the US in '96 on a J1 to the Latin American training program that Gustavo told you guys a little bit about, which was a wonderful experience and a wonderful place to train. Then when I came to the US, I was pretty sure I was going to be an endocrinologist. So kind of interesting how things turn out. I always liked critical care. I flirted with ID and eventually settled down in pulmonary and critical care, mostly because of the critical care, to be honest with you. I like the physiology of pulmonary medicine. I remember seeing one patient that was just started in Flolan that I took care in one of our mini units on the floor as a resident because he had a line sepsis, and that was the extent of pulmonary hypertension that I saw. Then I went to the Cleveland Clinic for my fellowship, and what drove me to sort of go deeper in pulmonary vascular disease was actually science. I met probably one of the most consequential people in my academic life, a woman named Serpo Ordrum, who was a physician scientist and sort of my godmother in the US here. And she was doing work in the lab and translational work in pulmonary hypertension. So I had an interest in science, and I didn't know what I wanted to do in science, but I started working with her, and she was this ball of kindness and enthusiasm and support. And she took me in, and at that time, Dr. Ride Wake was kind of a young buck too, and so he was like being mentored by her, and he was kind of another co-mentor to myself. And it's funny because I actually we took care of a lot of patients with PH there, and it was a bit of a thing. I actually didn't like it at the beginning. It was more because the staff that I worked with and his nurse were not a very nice group. They were fairly condescending to trainees and stuff. And I actually didn't like pulmonary vascular disease. So I like the science a lot. So I kind of finished my fellowship, and I had an O1 J1 visa, and I was like, what am I going to do? I enjoy this. I want to do more science. And Serpo kind of to help me, and she started talking to people, and she had spent a lot of time at the intramural program at the NIH in these glory days when Ron Crystal was there, another storied and controversial figure in the world of pulmonary medicine, but he put the pulmonary branch there, which was a pretty famous place that trained a lot of leaders in pulmonary medicine if you're interested in the history of pulmonary medicine. And so anyway, so she started looking for places there because she worked there, and she knew this young guy who was doing work in sort of nitric oxide signaling and sickle cell. His name is Mark Gladwin. I'm sure all you guys know who the dude is. He's now the dean at School of Medicine at Maryland, and she connected me with him, and she sent me my CV and said, "Hey, this guy wants to do science. He wants to be in the lab." And within 5 minutes of the email, I get a call from this guy who wouldn't stop talking and talk faster than I did, and it was another ball of enthusiasm. And Mark Gladwin said, we gotta do this, I do this, I do that. He sent me about 10 papers. I didn't understand 9 of them. And then I came over to the NIH and came in as a postdoc and started working with him. And that's why I started doing, a little bit of, pulmonary vascular disease in the context of sickle cell. Started working, trying to understand the physiology of these patients, cathing people, doing exercise studies and learning biomarkers and stuff. And there, the good thing that happens is that I was working for the federal government. So that gives you an advantage if you have a J1 visa and you're doing a good job. They hired me as staff there. So it's like after a couple of years as a postdoc. And because of that, I could waive my visa there. So I got a national interest waiver visa working in sort of science, got my visa waived. And then when Mark went to Pittsburgh, I was just debating, do I stay at the NIH? Do I go with Mark or do I go somewhere else? And another sort of chance encounter, I was at the chess meeting in Utah, don't know how many years ago, and I bumped into Skip Garcia, who's another kind of legendary figure in the world of pulmonary medicine. And I had some publications and stuff, and he looked at me and go, Roberto, are you happy at the NIH? And then started the major sales pitch. He's a great salesperson when it comes. So he recruited me to Chicago. I got my K there, went from USC, UIC, build my lab, sort of build a PH program from scratch there at UIC, and then came here to Indiana, and I've been here for the last 7 years. So combination of serendipity, hard work, dumb luck, and a lot of support and a lot of people who care about me, who believed in me, and who created an environment that helped me succeed.
Thank you very much, Rod. This is incredible. And I think for many of us in the community of pulmonary hypertension, we could say that serendipity has played a big role. And then just FYI, I wanted to bring up the fact that, I don't know, many of you may know the name of Norbert Buchel. Norbert, when he first came to the US, he wanted to study psychiatry. And then he decided to go for internal medicine, and then eventually became who he is now in the pulmonary vascular disease community. But that's another thing that he every now and then he thinks that if he could do it again, he probably would have gone psych edge. But thank you for not becoming an endocrinologist.
Thank you, Roberto.
Roberto?
Thank you, Pepe. Now, it's my pleasure to have Belinda Rivera Lebron. Belinda did her in Puerto Rico, University of Puerto Rico, and then Universidad Central del Caribe. And then she moved to Boston University, that's back on 2007. And then, Belinda, you went to Penn, where you did your pulmonary and critical care fellowship, and then you got your master in science and clinical epidemiology. Belinda, what impressive background. Could you tell us about you coming from Puerto Rico to Boston and developing your career in pulmonary vascular disease?
Yes, thanks for having me. So I mean, we share lots of experiences, as you were gonna probably hear from me as well. So when during my medical school, as I was doing some of the rotations in third and fourth year, it became very apparent that there are so many limitations in the public health care in Puerto Rico. And that led me to do sort of away electives in the United States and got a little bit of experience of what medicine was here in the States. And that led me to a realization that I was like, wow, there's so many things that can be done and offered that back at home, I felt that they were not available. So I was very differentiated to like moving to for medicine training, for internal medicine training after medical school to the United States. So when I applied and then ended up in Boston University, so very similar to the University of Miami, Boston University, a lot of underrepresented minority patients and diversity really in the residency program. And that's one of the things that made me really comfortable right away, right? I felt at home. I felt that I belong. I didn't feel like an outsider. So going through a residency there was very comforting in a way. Made the transition easy for me. But in terms of specifically pulmonary hypertension, so I didn't want to be endocrine. I actually wanted to be a hemonc. I wanted to do clinical trials in hemonc. That was my, forever I wanted to do that until I did an ICU rotation, second or third month, maybe September or so. And I met Hap Farber, who similarly also admitted a young girl, PAH, like idiopathic PAH. She was put, also dying and was put on Floland 2 days later. She's like a different person, right? I mean, I think we all see that. We've also all have that patient in our minds where we first met that went on IV therapy that clearly had this remarkable recovery. And then I was like, oh my God, this is what I want to do. I've also never heard of pulmonary hypertension ever until that point. And I was like, forget hemonc. So, and then, hemonc, I was like, oh, every patient had neutropenic fever, at least in the inpatient side. So, I really like critical care and attracted to the fast-paced procedures, etc. But I hated pulmonary during my second year of medical school. So I was like, oh my God, do I really want to do pulmonary? But I really loved pulmonary hypertension. I really like pulmonary vascular disease as well, physiology and how unknown it was at the time, and there was very little knowledge of it, and widespread availability of therapies, etc. So I actually went into pulmonary critical care with the caveat of I am going to do pulmonary hypertension for the rest of my life. I will see every other pulmonary disease for 3 years. I will see asthma for 3 years, COPD for 3 years. I'll see anything for 3 years, but with the goal of becoming or finding a job that would give me a niche in pulmonary vascular disease. So I ended up at fellowship at Penn, as you said, after Steve Kaywood was recruited from Columbia, and he then became my mentor during fellowship. And then helped me with getting the job that I am currently now, which again also recruited by Mark Gladwin when he was over here in Pittsburgh. So I think I share the serendipity in a way, being in the right place, the right time, but also I feel like, a big shout out into this pulmonary vascular disease community in which I think we help each other. And I'm sure that any of you who are here listening will be able to reach any of us and in a meeting or separately, and we may be able to connect you to the right person if we can't help. So I think that that's a good thing about just in general about pulmonary vascular disease. So yeah, I'll stop here and let you continue asking other questions.
Thank you, Belinda. And thank you to all of you. It's just so interesting to hear how each one of you started and how, in different ways, many of the same names get repeated one way or the other. We have Mark Gladwin and other examples. But now, Eda, let me get back to you. You told us about your background. You told us about you moving from Germany to the US, going to Stanford. As somebody who has relocated many times across different states, it's never easy to do that process, So I guess I wanted to ask you, Eda, you moving from Germany, how difficult was that? I don't know if you had a family already with you, but relocating is never easy, and relocating to a different country is never easy as well, and you developing your career after. If you could tell us more about your perspective about that.
I don't know. I mean, I was an exchange student when I was 16 in the US for a year, and this was 1983 to 1984. So that was a total different era because we didn't have email, you could hardly phone, and I was really away for a year, not speaking German, and just, yeah, totally disconnected to Europe. Coming then back here in 2002, I feel it wasn't, I could still connect, with my people from home, with my family. I could listen to German news, I could like there's like a big community here that's international, so it doesn't have to be German, but then yeah, I mean, I felt mostly at home with international people because they were in a similar situation. So that's kind of what we did. I came with my boyfriend at that time. We married here so that he could stay here. And then we also had like a family during or like started a family during my postdoc. So, and both of us are German, so we just speak German at home. Our children speak German. So it's kind of, we're still, I think, living a little bit our culture. It was difficult because my parents passed away while I was here, and so it's kind of your moving further and further away from your home country and have less connections maybe. But you're building something here, and we at some point, I mean, like similar situation as probably many, that the idea was only to stay here for 2 to 3 years, but then I really liked it. I loved the flexibility of doing research here because here you can just focus 25% or so clinically and then the rest research, and that's not possible really in Germany. You often have like 50-50, and you can do research after work, but it's not really that it has this kind of emphasis, and also funding like that. So and then living in like California, and we like the outdoors, so we really wanted to stay here or like initially stay here. And so I don't know. I mean, looking back, I mean, I think what I think was most difficult, not necessarily that I was in a different country, because I felt this is exciting, and I always felt I'm not ready to go back, and at some point it was like, well, are we at all going back or not? And essentially our daughters had an assignment at school where they had to ask their parents why they immigrated to the United States. And before that, we were always saying like, oh, we're not ready to go back. Not yet, not yet. And at some point we felt like, oh, maybe we did immigrate to the United States, but it wasn't kind of in our thinking that we would really do this. But so I think the most, so it wasn't so much the difficulty being in a different country, but I think this insecurity all the time. You kind of do your postdoc and then you don't know, will you be able to stay longer? Will you get your green card? And then will you get a faculty? I mean, for like years and years and years, you couldn't really plan anything because it was always just 2 years and then another 2 years. I mean, maybe this is exactly the same as Americans feel, but I felt this was like being in your like when I came, I was in my early 30s, so you were supposed to be a little bit more established, always living in one bedroom apartments, so I think this was kind of it was an insecure time and a time with not much money, and but we just did it because we like to be here and loved our work, I think, and so at some point it became a little bit more secure. But so I don't know how other people experience this, and maybe that's normal for the American system, but in Germany it's often you enter like a secure job situation much, much earlier, and yeah.
So
Thank you, Eda.
I
Thank
do
you for
have a
that.
question. There's a question in the chat box related to like what exactly would be needed to do should somebody will want to come to the US from scratch to do fellowship in lung vascular disease. And I think this is something we need to address in regards of like more to a bigger picture. Most of us kind of like had some sort of a sneaky immigration history where we kind of started doing 3 to 4 years and then research here and then some mentorship that and finally got into residency. But things have changed a lot in the past like 5, 7, 10 years. So if you guys were to be able to give, like bits and pieces of advice of what would he need to do moving forward to not necessarily just even do a fellowship, but even kind of like begin to start a career here in the US. Is there any specific tips that
Yeah,
you guys
I
would be
can
able
take
to
some
give?
of that. I can take some of that because I also lived that as somebody who's now hiring people as a division chief and seeing the paths and those things. So I think specifically to Manuel's question, I think it really depends on what your ultimate goal is. So like Eda said, I think a lot of people come, well, I spend my time here and then I go back to my country because I'm on a J or something. I mean, I think I had a pretty traditional route. I came here to do my training medically, and I came straight out of training essentially to do training here. I think that's probably the surest way to get you to stay in the US with the most freedom allowable. If you train here, you come and do residency, fellowship, you are much more free once you get rid of your visa attachments to sort of, practice wherever you want, so to speak, right? If you come in, depending on the place, depending on the states, some places, if you don't do residency here, they won't take you, right? Some places, it's easier. You can do a fellowship in a subspecialty and then some states will take you. So it's really variable. I think you have to have your objectives in mind, first of all. And I think the second part of it is that you have to understand that it's going to take a long time. And patience is a virtue when it comes to those things. whether you fix your visa before or after you start your training, or it is a strategy. But I think the first step is to understand what your goals are, and understanding that goals might change, and then you're going to have to roll with the punches. But I think the surest way, if you want to be a practicing clinician, if you want to have freedom of movement, is to actually do the whole thing here. That's sort of my perspective.
And what I can add to that is, I always tell people the path is hard, but it's clear. And I don't know if that applies to other places, but in the US, as an international medical graduate, it's very clear what you need to do to get a residency position, right? You have to pass the English proficiency test, and then you have to take the steps. You study hard, get good scores. It's very clear. And what I like about it is that it's also fair, right? Because it's exactly what the American students need to do, except for the English proficiency, right? So I think that that's what I like about it. It's the pathway is not easy, it's very hard, but it's very, very clear. And then, once you get here, me, for example, I'll tell you my story. Like, I had no idea about visas. I came in with a J1. I thought that was it. I had no idea about anything else. So that's a barrier, right? So once you realize, and similar to Ed, actually, I didn't plan anything, but as time went by, I was like, yeah, I like it here. I miss my family, Peru, started in Miami, which was an easier transition, obviously coming from Latin America. But the longer I stay here, the longer I wanted to stay, and I really liked it. So that's the second piece of advice that I would give. You can plan things, but I think you need to do what feels good for you, because you may say, okay, I want to have a career in the US, but you may come here and find out that you don't like it here, right? And in which case you have to adjust. I think in my case, I was planning on going back, but I ended up liking it here. And when I was like, all right, I want to stay, that's when the visa issue started to weigh on me, right? That's a massive barrier. Like Roberto is saying, fix it, right? And I didn't realize this, but then that's where the waiver comes, right? And then the second thing around that time, I realized that I wanted an academic career, and I started doing work with Dr. Dweck, my mentor, on biomarkers in pulmonary hypertension. We started getting some publications out, but then, and I also wanted to get funding. And as a J1, you're not going to get your green card anytime soon. And then I was like, oops, I cannot get federal funding, right? And so that was a massive barrier in my career. And I think that in terms of at least federal funding, that delayed me. So that's my third piece of advice. If you are thinking, although again, you cannot plan for sure, but if you're thinking you want to get a funded career, perhaps an H1 is better, because then you can get a green card faster, right? That's a really discreet piece of advice, which in my case, I didn't know, because the J1 will take you longer, right? The waiver will give you the H1 visa, and only after that you can get a green card. So for me, those were a bit of the barriers, right? Especially for the funded career. I got my K a bit later than I wanted, because for many years I wasn't eligible. So those are, a few pieces of advice that I can give.
Thank you, Roberto. Thank you, Gustavo. Very interesting perspectives. Belinda, let me ask you this type of question. So Gustavo mentioned some of the barriers you may face as you are pursuing your training in pulmonary vascular disease. And some of those barriers are understandable for an international medical graduate, but your case is quite interesting to us as somebody coming from Puerto Rico, as a female coming from Puerto Rico. Did you perceive that as a barrier as you were pursuing your dream of becoming a PH and pulmonary embolism expert?
I think that it's not as much doing training itself, although I'm sure I just maybe did not realize if there were some comments or attitudes towards being both a female and minority. But actually, I can tell you my experience as, once I started being, an attending faculty, one of the first assignments that I was given by Mark Gladwin was like, why don't you just start this PE team, right? And at the time, I didn't know what was PE, and the other thing was, I was like, I thought you hired me to do pulmonary hypertension. I don't care about PEs, so I didn't, it's so. But I was like, a young female first year faculty, not knowing anyone. And then I had to arrange for multiple meetings with, chief of vascular surgery, the chief of cardiothoracic surgery. And I, expected to convince these other people that this idea of becoming a team was a good thing. So I think that gave me it was a challenge, but it helped me but just come out of my comfort zone and push through barriers that somehow some of them are you self-imposed, right? You think how are you supposed to be meeting this young with people that are so high up yeah with inexperience, but I think that if you try to get out of that comfort zone and just face it head on, I think that is probably the best advice I can give. Just like you don't sell yourself short. Don't think about the potential limitations and just do it. I think that may be the way to overcome some of the challenges is not to focus on the limitations, but rather focus on the abilities. And if someone is not welcoming, then you move on, and then you go to the next door and knock on that next door, and somehow everything will work out. If you, I'm a firm believer, if you're, hard work pays off. So it may not work out the first time on the first try, but it will eventually.
All right. Thank you very much for that. So I think we have another question here in the chat from Himanshu Deshwal. He is somebody who's had like a IMG training. Like many of you mentioned already, that J1 visa is like a very typical start, and then sometimes it's very difficult to move towards the rest of career development because of the waiver process. And he is wondering, once you have to take this waiver route, that for many of us becomes a very problematic thing, because for career development, it kind of truncates your trajectory in some aspects. So what advice can you give someone who has to go through this waiver route, and then once they get freed in regards of like the green card and immigration, what is the best strategy to kind of like pivot back into like an academic career? Maybe not necessarily in pulmonary vascular disease, but in this particular case, that's what he is just wondering. So any advice?
I mean, I don't know how old he is and what he would want to do, but I think because there are now many centers who offer pulmonary hypertension fellowships for 1 year. So it started kind of with Stanford, but I know, University of Pennsylvania has them in like, I think the Boston area, they have them. I think they are starting these. And so that's maybe a good, because this is, Roberto did one, at Stanford, and that's maybe a good entry into a system. And then this university knows then how well you can diagnose, assess, treat pulmonary hypertension patients, and then you might be able to stay on at this university as faculty. At Stanford, we have a little bit difficulties recruiting pulmonary hypertension faculty from outside, because we don't know how well do they do right heart caths, how well do they, and so we often use our own fellows. So I don't know whether you want to do another fellowship for a year, but many different sites now have this. Otherwise, it's to then apply to these centers, because they often are expanding, and then to see whether they need additional attendings. I think that's also something. Yeah, because I don't know how comfortable you feel starting, your own center. I think depending on, because you said you have good PH training, so depends a little bit. So that's my comment.
Let me comment on that.
Mhm.
Maybe Roberto and Gustavo can have some input. But Himanshu, he already has a lot of experience in PH. I believe he trained in Cleveland.
Oh,
So
okay. Mhm.
this is an interesting scenario. Is somebody with a lot of expertise in PH who's doing his waiver. And I guess if I understand the question, he's trying to go back to a large academic program with PAH. Maybe Roberto and Gustavo can have some input
Yeah.
for Himanshu.
Yeah, I would add, what were your connections prior to going to the waiver process, right? Do you have a connection to a place where there might be availability? So that's one way of thinking about it. Who are the people who you know there that might know other people? And going back to your network and see, hey, if you feel confident with your PH skills, number one, and you're ready to practice PH, and it's about finding the network and finding the people that may be available or may have availability. And I think the best way to do this is through people that already know you, who can recommend you, because that's an easy sort of path, and it's a small world. So if Gustavo tells me, hey, I have this person who was my fellow, who trained with me, who's great, and are you hiring? I'm gonna look at this person differently, and I'm going to take a deeper look than somebody who sort of randomly calls me, hey, I'm working in this private practice doing a waiver job, and I want to do PH. It's still a valid way of doing it, but if you do it through connections, it's probably easier.
Yeah, no, completely agree. I think, and I know Himanshu, but I wanted to say something sort of a bit broader. To the extent possible, like if you know, say you have a J1 and you need to get a waiver, right? Because you're staying here. If you are interested in a academic career in PH, of course, the easiest way to the extent possible is to get a waiver in an academic institution, right? I know, and I did it a long time ago. I was lucky, actually. I did my waiver at the Cleveland Clinic. That's an interesting story in and of itself. But back then it was possible. Now I know that sometimes there are scattered possibilities here and there, but I think in general for the audience, if you are a J1 and you're interested in an academic career, to the extent possible, look for waiver opportunities in academic or at least academic associated places. Now, those are very difficult, of course.
Yeah, but
for
it's a very
most
good
people,
point.
yeah, but for most people that may not be possible. And yes, Himanshu is a good example. So yeah, Himanshu was a resident with us, so obviously he had a significant exposure to PH, but then he moved on somewhere else, and then coming back, it is difficult, right? So I would echo Eda's earlier comments. I think that in this day and age, two things have happened, right? PH has become more competitive, and two, the field of pulmonary vascular disease has become way more complicated, right? When we all were studying, there were a couple of medicines. Now there's so many, and there's so many other ways of thinking about this disease that I think it is increasingly more important to have dedicated training. And so, as Era pointed out, there are many places that, following Stanford's example, ourselves included, we have at the Cleveland Clinic, we do have a pulmonary vascular disease fellowship. So I think that is a good way to sort of get back into the academic setting, because A, you will get more training, and B, then you can again foster those connections that will allow you to find an academic position at some point. I completely get it also. You may wonder, after so many years, yet more training. That's a different conversation, right? I mean, takes too long. You want to make money at some point, but if you come off from a waiver, maybe another year of training, pause in the money making experience, and then get back to the career that you really want, may be worthwhile, right? There are many other aspects, of course, family, time, money constraints, etc. So that's kind of what I would sort of think about your best way to get back into PH in an academic position.
All right, thank you, Gustavo. So we're running out the hour. I do have, I think, like a fair amount of conclusions for what we've talked about for those who are still in the meeting with us. I guess we can all say that we believe that mentorship is a central thing, that finding someone who's going to help you through the process, not necessarily by training, but also kind of help you understand how to plan your career development is it's critical. That we always have to anticipate based on understanding what your goals are, what you want to do in the future. What is it that you need to do with your visa, and anticipate that there are going to be barriers on regards of like obtaining funding, obtaining positions, obtaining faculty, depending on what your immigration status is. And I guess that networking is critical. That the pulmonary vascular disease community is small, and the more you connect with each other, you can increase your chances of like developing your career within this field. But I do have one more question, and I guess this is coming from the physician scientist perspective. Can any of you guys like maybe talk about like a good timeline? When to start applying for grants and when to start applying for certain things based on papers, from the perspective of like a program who may not necessarily be a physician scientist training program and is somebody from internal medicine wanting to do research. And what would you be your like, I guess most important tips of like in regards of like, hey, listen, I would start this time and because you need to anticipate X, Y, or Z. I don't know who wants to like.
That's a complicated one. I have a couple of scenarios. I think there's a very linear one, which is the one, let's say you're an FMG, you worked in a lab, and you got your green card, and then you go to residency fellowship, and in that situation, you should try and go to a place where there is a training grant, where they can put you on a training grant, and you can start organizing your research career during your fellowship. That's, in practical and realistic terms, is going to be the first time in your life that you're going to actually have time to protect yourself and to build a team around you and to do science, if you're talking about science, right? That time doesn't come back and is a very valuable one. So I think that will be the sort of the ideal scenario. If you're a foreign medical graduate, as Gustavo said, and as I mentioned, and we're not going to be, people are not even going to look at you for fellowship in some of these places, because most of them have positions that are funded by the NIH with the T32s, and you can only take people with the very least a green card. So then you have to be creative, and sort of, I think the most important part is to sort of, try to emulate if you're really interested in science, I'm being very specific about science, try to emulate what you could get on a T32 doing your fellowship. Like most pulmonary and critical care fellowships, you have 18 months of training that's required from a clinical perspective, right? So then talk to your buddies, talk to your program director and say, hey, I really want to do science. Give me a year or a year and a half in the lab, and I'm going to go to town. Or a lab is very broadly defined. Let me be very clear. Doesn't need to be bench. It could be outcomes research, it could be whatever, but research, right? If you want to write grants, if you want to have science. And then your currency is going to be you're productive, you publish, you start to develop name recognition. And as you do that, you need to start thinking about how am I going to get my visa fixed? There's some sort of, intermediate pathways that can help you do that. For instance, when I first came to the NIH, I came on a no visa, right? Which doesn't get rid of your waiver, but gives you time here. And you can build your science, build your reputation, and depending on the institution you are at, you can start working on your waiver and those kinds of things. The problem is if you don't do a science waiver, is that a lot of these places, if even in an academic institution, there are some requirements in terms of times on facing patients and doing clinical work. For instance, we do waivers here, even in our health center,
Wow.
And you need at least 40 hours of patient facing time to qualify for it. And it's already a pain in the butt to get people waived here, but it's doable, but virtually impossible. The VA can sometimes do that. So you really gotta be strategic about how you build your time. And as Eda was saying, you're gonna have to work extra hard in different hours, that are non-clinical to build that. So once you build your scientific base and you have name recognition, publications, and the skills, once you get your visa fixed, you already did the baseline training that's necessary, and then you can start applying for grants as a K. I also got my K fairly late relative to what it is these days, but now everything is getting later and later, mind you guys. So we have to remember that. So I think if you're on a visa, you have to kind of emulate the pathway that non-visa people have and focus on your productivity and your protected time to build your science. So when your visa gets fixed, you don't have to then start your science stuff.
What I also like is, I think there, like, as you can see from our group, there are many, many ways, right? So I joined research late, and I did like a dedicated postdoc in a lab, others came to the US much earlier. So I think being open to different ways and just also following what you really want, because there's no right way, right? But we at some point all decided, no, this is the way I want to go. And then you try to find how do you make it work? But I think we all have different starting points, right? But we all at some point made it through the system, right? So it's kind of, I think that may be also helpful.
Yeah. If there's no passion, if that's not what you want, it's too hard to do it just because, right? Absolutely.
Mm.
All right.
Yeah,
Well,
I
this
think-
is incredible, Roberto, I guess.
Yeah, no, thank you all for joining us. Really beautiful conversation. Something Belinda mentioned earlier today, it's going to work out if you have the energy and the passion and are willing to adapt to whichever scenario comes your way. I think it will eventually work out. But Belinda, Gustavo, Roberto, Eda, Pepe, thank you all so much for joining us. I'm hoping we will join again sometime in the future to discuss other aspects of a career in PH. And thank you to all of you for being with us on a Friday afternoon. And we'll join in a future webinar.
Yeah,
And
thank
Merry
you.
Christmas
And
to all.
one fine thing, this is a nice community, and don't be a stranger. Don't be afraid of asking. Don't be afraid of calling. It's always it's a thing that it's really satisfying to me, is to talk to people and to try and help people, and especially people who had similar experiences than I had being an immigrant. And it's important to me to keep the fire going with the immigrants and things. So I think it's important not to be shy too.
Same here, yeah. Mm-hmm.
Thank you all
everybody.
once
Right, well,
again.
thank you.
And enjoy the holidays, okay?
Thank you.
Happy holidays.
Thank you
Bye-bye.
for inviting
Ciao.
us. Roberta and
Ciao,
Christian.
everybody.